I'm here with the infamous and dear old friend of mine, Dr. Tom Levy. And Tom and I have known each other for what I think we're probably going on 25 years now, Tom. Being
That's
my,
about it, yes.
yeah, yeah, in the mid 90s since the days of Hal Huggins and the research that we did on root canals back in the day. And, you're the epiphany and the life story that you've had of all the influences that Hal had on you and all the influences that Hal had on me as a young dentist, and really what was just so profound for me getting to know you was that you were a practicing cardiologist and you decided no longer to practice cardiology to become an attorney, to really dive into this head first, dive into this conversation head first in such a way that was powerful, so that you could really honor and support Dr. Huggins through his legacy with the truth that was becoming apparent with dead teeth and root canals, and including root canals and cavitations and mercury. And yeah, those were the big things back then. And fast forward to today and all the things we know and all the books that you've published and all the science that we have, is really just, now we're at just such a point with this conversation about the mouth that it's just so important to the overall health of a patient for so many reasons that we're going to discuss today. But that was just such a wonderful red carpet for me to walk upon as a practicing dentist, to have this kind of leadership and knowledge coming from Dr. Huggins and from you and Boyd Haley, and of course we can fill in the blank a lot more than that. But and then just elevating the practice of biological dentistry to where it is today, where people can really come to a biological dentist who's well versed in the toxicity and the sepsis and the need to protect the body through the experience, and using biological dentistry and medicine, biological medicine and dentistry, so that we can really give the patients what I think they want. And what I think they want is, they want an experience that is not painful and doesn't have a lot of inconvenience to it, and their bodies are transformed, if not soon after the surgery, then not long after it. And that's why I always wanted to practice biological dentistry in such a way where to make dentists become healers, not just tooth mechanics, and really merge the two between tooth mechanics. Because of course we have to fix things in the mouth that are structural, but we also have to create conditions in the body, and that are conducive for a healing. And as of you have so eloquently said, through the years, the disease in the mouth is just such a huge source of toxicity that it really, like, a person really can't have health if they don't have a mouth that's in coherence with the rest of their gut system and the rest of their body. So yeah, it's just such an honor to be here with you today, Tom. I've been looking forward to this conversation for a very, very long time. Let's just dive right in with this conversation. I'd just like to hear from you what you're seeing on the current state of medicine and dentistry from your angle.
Well, the current state of dentistry and medicine is evolving positively, but still pretty slowly.
Yeah.
Having said that, I will say, though, that the pandemic accelerated the recognition quite a bit, because so many people on the planet now realize what a complete and total fraud, and that's the word I use, fraud, that most of modern medicine is, combined with the fact that a large number, I'm not ready to say a majority, but a large number of the doctors in modern medicine, quote unquote, really couldn't give a damn less about their patients and do not put them number one on their list of considerations. So it's quite something that has to be overcome, but it really made a big deal when it finally filtered down to the public how many people were needlessly dying during the pandemic due to completely suppressed medications, due to the attempted defrocking of physicians. I mean, I had reprimands on my license in Colorado and The American Board of Internal Medicine picked up on that and took away my certification in medicine and my certification in cardiology, all because I spoke the truth. So it's a sad state of affairs, but quite honestly, it's a necessary state of affairs, because until people really and truly can wrap their head around the fraud that is medicine today, they're not going to be as ready for the incredible benefits of orthomolecular medicine in combination with the concepts of dental biology and dental medicine, which is what I call it. Dentistry is not some mechanical, independent practice. It's part of medicine, a vital part of medicine, and it still remains to be regarded as that, which is a shame. But that's what you and I and other people like us are trying to do, is point out that, guess what? Guess what? The mouth is part of your body. And every infected tooth it is part of your body. And every toxic substance you put in it is in your body. I mean, it's not rocket science, but for a lot of people and docs to appreciate it, it seems like rocket science. So let's go about disabusing everybody of those crazy ideas, John.
Yeah, exactly. Yeah. And if a patient doesn't have a healthy excretion mechanism, or if they're not having good, bowel movements that are proper, then the infections just basically back up. And then here dentists are going in there and doing all these septic procedures with no protections other than oral antibiotics, which kills the friendly bugs before it does anything, before it ever gets to the blood. And, that's, and the pain pills and the opioid epidemic that is, I think, largely responsible due to the dental profession. And, because we have to use pain pills because we don't create good conditions inside of teeth. And so, this whole, like you were saying, this whole notion that the mouth and the body are connected and the body and the mouth are connected is really the future of dentistry, the way I see it. And like you said, the future of dental medicine. So that we can.
I think dental medicine should be a subspecialty, like gastroenterology, like internal medicine, like urology. You're a specialist in dental medicine as well, and it should be a separate residency and fellowship, during which time, of course, you get the hands-on training that you need. But hand in hand, you're learning physiology and biology and chemistry as well or better, hopefully, than the internist.
Yeah, absolutely. Not only in treating teeth, but when taking teeth out, right? And subsequently what happens to the bone marrow when it cannot heal properly, and that being, studying dental medicine in that realm and what we now know about that. We'll talk a little about that later. But I also want to point back to like anyone that's wondering, well, then how did it get that way? And I always think of the Flexner report from like the 1910s, 1910 to 1920, and what happened to the medical school curriculum at that time. And basically when alternative medicine, homeopathy, for instance, and, natural medicine at that time was basically, what's the word I want to use here? It was just highly discouraged by John Rockefeller, because of his attempt at trying to shift the medical training towards a very allopathic, molecular, single molecule medicine, what I call it, coming from the science of the oil industry, then moving into medicine. And I think it was really at that time that the doctors were trained to specialize in the prescription of drugs.
Right.
And
Flexner started the drugs, and it's never stopped since.
It's never stopped since. That's right. And it hasn't stopped because, you give people.
Because the drugs support the medical schools and support the journals. I mean, it's all incestuous as hell. I mean, hey, money, money, money. And even if you go into medicine with wonderful motivations and you want to do research, guess what? You still need to have money to do the research. And you're always running the risk, especially if you actually have good morals, of is your research going to conflict with the desires and goals and economic gains of the person or the institution giving you the money for research? So it's all inherently incestuous.
Yeah. Yeah, absolutely. And also from the standpoint of the people too. Like if a doctor gives a medication and all of a sudden they feel better, regardless of the side effects.
God forbid.
Yeah, you give people what they want slowly, and then they think it's working in the moment, and then they don't really associate the other health problems that now or later are part of the problem. And we certainly see that in dentistry too. So well, you're right, it's been a really long time, and this whole COVID thing was a real eye-opener. And I think a lot of
some people didn't open their eyes till the third or fourth year, but they finally did open them.
That's right. Yeah, or the third or fourth jab too.
Yeah, you and I saw it after the second or third month, but hey, things take a while, and
No,
and eventually the world caught on.
exactly. And with all the censorship that was apparent at the time, it was just mind-boggling how the conversation was just not allowed across all networks. It was just not allowed at all. And so, I feel, anyway, doesn't matter how I feel, but I think people really, if you get your information from somewhere, then, and it's all the same at that point, then here we are. So, well, let's, unless you have anything else to say about that, we could start deep diving in on the mouth.
Dive in, and the water looks fine.
Good. Well, so when your book, The Hidden Epidemic, came out, and I have a copy of this book right here, it reminds me of the day where you came into my office and you were so excited to now have the study, the Pessi study, that your words were, now we have not just statistical significance between a dead tooth and a heart attack, we actually have cause and effect.
Right.
Yep. And I've never forget that day. And I was like, oh, really? Well, we've been kind of wanting that for a while. And so I guess if you could, let's just start there with talking about the Pessi study and the blood clot and in the heart attack victim. And I'd like to hear in your own words, really, what was so monumental about that study?
Yeah, I'm trying to think. That's probably close to 10 years ago now, more or less.
Yeah, 2014, actually, I believe.
2014, okay.
Yeah.
Dr. Tanya Pessi in Denmark, Denmark, had a very unique situation. She was a team of researchers, and they had this incredible alliance with the clinical side of the institution, the medical school side, so that they could collaborate on basic scientists doing studies with clinicians, which is a pretty unusual sort of scenario to be in for research these days. As it turned out, somewhere along the line, I guess Dr. Pessi got the certainly solid and brilliant idea that all the pathogens coming from the mouth were the primary causes of the clots that develop and cause heart attacks. And very, very simply, very, very elegantly, she devised a study that coordinated with the cardiologist, the invasive cardiologist at the institution, and I think it was on the order of 100 patients. I might be off on that, but on the order of 100 consecutive patients, more or less, presenting with an acute heart attack, ST elevation on the EKG. They did the angiogram, and generally speaking, when you have a true heart attack and the pain, you do the angiogram and you'll see one of the blood vessels just stopped. It's blocked off. All the blood vessels are going around, and this was blocked off. Well, the hypothesis there, and it's true, is that these acute occlusions are not caused by hard atheromas. They're caused by soft platelet clots that acutely finish blocking off what had already been a previous high-grade stenosis. And so in that regard, then, she got the cardiologist to do aspirations. So They went in there and they actually up to the clot, sucked hard, pulled part of the clot out. I assume they probably did angioplasties too, but the point is they sucked out this clot that was causing the rest of the acute occlusion and then analyzed those clots.
Yeah.
Well, virtually all of the clots had oral pathogens concentrated in them. Not only did they have oral pathogens, they had 16-fold. That's 1,600% more pathogens in it than the surrounding blood.
In the clot.
In the clot. And so that's when I probably said to you that, forget about link, correlation, statistical correlation. This is cause and effect. Don't tell me an innocent, uninfected blood clot suddenly developed here, and then all of a sudden it became massively infected and colonized with pathogens from the mouth. And that goes along very well with another study done by Dr. Ott in 2006, I believe. And Dr. Ott looked at 38 patients who had known coronary artery disease. They already knew for a fact that they had blockages, and he did consecutive angiograms on these 38. And when he did the angiogram, he did a procedure called atherectomy, which basically, quite elegantly, is a roto-rooter. I mean, they actually burred out, scraped out plaque that was blocking the blood vessel wall to open up the blood vessels more, and they analyzed that plaque. Well, guess what they found? They found over 15 different species of oral bacteria, viruses, parasites, and fungi. Okay, and guess what? They found it in 38 out of 38 patients, which is, I always like to say, is pretty doggone close to 100%.
Yep.
and they did do some control studies that show there is no contamination of that type in any way, shape, and form in a person who does not have atherosclerosis but has normal coronary arteries. So the thing then, going back to Pessi, is you have atherosclerotic plaque that's been building due to the chronic inflammation of the pathogens that are being seeded from the oral infections through the lymphatic supply, through the blood supply, and then they finally reach the high pressure of the arterial side. In other words, they're released into the low pressure venous side. So nothing that just flows, no problem.
Right.
The moment it goes through the lungs, comes down to the left ventricle, and the left ventricle, boom, contracts. You go from 10 millimeters of mercury to 120, just like that.
Yep.
Which actually embeds the pathogens with a physical pressure into the endothelium of the coronary artery, which then starts the chronic pathogen colonization that literally consumes all the vitamin C in the blood vessel wall, because that's a pro-oxidant and it consumes the antioxidant. And as the vitamin C is consumed, the depleted antioxidant state is synonymous with inflammation. And then what does inflammation do? Inflammation heralds the acute immune response. And what's the first cell to show up in the acute immune response? Is the monocyte that has 8,000% more vitamin C in it than any other molecule, than any other entity. So the whole point being is the pathogens start and they initiate and they prolong. They would resolve, except for the fact that it's not going to resolve until you resolve the mouth. So if you got rid of all the infections in the mouth, the body would heal from this. And if you didn't have your heart attacks already and you did the proper orthomolecular therapy, you can reverse those atherosclerotic plaques. But you'll never reverse them as long as you continue to feed new pathogens and new toxins into the coronary arteries.
And don't you think, how many people have suffered a heart attack not long after having their teeth cleaned, just from the mobilization of the what's down in the periodontal pocket?
Yeah, well, what happens there too is those weren't the first pathogens that enter their blood, so odds are they already had some atherosclerosis, and then the stirring around brought on the acute soft blood clot that Dr. Pessi identified to finish off the blockage in the heart attack. Yes.
Yeah. Yep. Or even have an infected tooth pulled.
Sure.
Yeah. Any of these things just kickstart that. And, even antibiotic coverage, certainly of the people that don't have antibiotic coverage at the time, but even with antibiotic coverage, I could see that that's still not enough.
A grossly infected tooth, I'm sure you agree.
Mm.
I mean, you have lots of different reasons. I don't need to tell you why a tooth might be extracted, but if you really have a horrible, sore, bust out, infected tooth, I mean, you're not going to be able to prevent completely some dissemination of toxins and pathogens in the blood. It's just going to be a question of amount. But what you want to do is you want to be prepared. And that's what Dr. Huggins started many years ago with intravenous vitamin C.
That's right.
And then he didn't do it just for the grossly infected teeth because it's good for everybody. But you especially want large amounts of vitamin C circulating in the bloodstream when those pathogens and toxins get in there. That way they're unable to set up shop in the heart, on the valves, and different areas of the body. So these days, it's ironic, these days we've had a situation where, on my own personal opinion, is the FDA's main response to vitamin C after they found out too late that it was good for people in the pandemic was, well, it's probably not going to be cool for us to try to ban vitamin C, so let's make it expensive as hell. And I mean, since then, the IVs have like skyrocketed. I mean, oh gosh, not too many years ago, you could get 25 grams of vitamin C, for $8 in a vial. Now you spend $50 for it or more. All right. And then, of course, that's not talking about the whole apparatus and employees and everything to set it up.
Mm-hmm.
But anyway, the point is the FDA inadvertently pushed us into a situation that I'm thinking is turning out to be even better. And what's even better is, as you know, I've worked with Live On Labs for some nearly 20 years now with what's called liposome encapsulated vitamin C.
Mm-hmm.
And I have been overwhelmed with how taking mega doses of that for several days before, the day of, several days after, works perfect on mercury protection protocols, infection protection protocols, the whole ball of wax.
Mm-hmm.
And I think as time goes on, we're going to find that because for a long time we just arbitrarily say, oh well, just take 2 or 3 or 4 grams. But when you start taking on the order of 10 grams a day of the liposome encapsulated vitamin C orally, you're vastly, well, I won't say vastly, you're clearly exceeding the protection and the healing capacity of a 50-gram IV vitamin C, in my opinion. So now, having said that, if I'm sick, what do I want? I want both. I want IV, I want the liposome, and I want everything else I can find. But I just bring this out there because there's a lot of dentists out there that I talk to at these different conferences that, of course, gotten very frustrated at the idea of how expensive IVs are. And all the feedback I'm getting is positive. Doing this on the order of, usually it's like 5 packets a day for 2 or 3 days, 5 packets before and after 5. So you have a box of 30. You have a box of 30 grams. And that's how it works out. And oh man, have I far more than this too, have I gotten phenomenal results. And I first had this is an interesting story. I was in Puerto Rico about 7 or 8 years ago. And my wife called me and she had gotten bitten on the cheek by something. And then it got infected. And now her eye was swollen shut. I mean, and she showed me a picture.
Mm-hmm.
And she was on whatever their maximal antibiotic therapy was, and it was getting worse. And she did have a little liposome C with her, and she had taken a few packets. And said, she said, well, you need to come give me an IV vitamin C. I said, well, honey, I'm in Puerto Rico. There's not I can't possibly be in Denver for 24 hours. So I said, boom. Like the old cartoon where the light bulb goes on inside your head. I said, wait a second, you have a lot of the liposome C, right? She said, right. I said, okay, this is like late morning. I want you to take 5 packets every hour, every hour, every hour, every hour, every hour, every hour, all day long until you go to bed. And then tomorrow morning, take a picture and send it to me. And
Yep.
she did that. She went through about 35 packets, and the next morning the eye was opening up.
Yep.
I'm not sure IV vitamin C could have done that good a job. So anyway, point being is the FDA forced us into alternatives that I think might even be superior to the one that's had the test of time. Because just don't anybody interpret at all that I'm against IV vitamin C. It's wonderful. It's just been made, sadly, horribly expensive.
Yeah, and not the average person has access to a nurse
And access to.
they can't learn in getting an infusion. And there are lots of these oxygen bars that are coming out now. Small businesses where you can get Myers cocktails at the drop of a hat. But like you said, for the people that just say, "What can I do right now?" and what can I do to protect myself when I'm sick, or I know I'm going into a dental procedure that involves sepsis and toxicity. Like you said, get a hold of some liposomal vitamin C and start mega dosing that as something that is just cheap and easy. And there you go. And
I might add to anyone who's listening, yes, I'm a consultant to Live On Labs, but I want to make it clear, I've never seen more fraud in the supplementation industry than when Live On came out with their liposomes. Everybody and their brother says they have a liposome, and most of them don't. So this is not just a unqualified support of anything you find on a bottle that says liposomes, because I'm sad to say so many of our supplementers really have no ethics at all. But the trouble is, they'll come up with something that says it's liposomal C, and the patient takes it and they feel a little bit better. So they think they got the right thing. Well, guess what? If you haven't been taking any form of vitamin C at all, and you start taking some form of vitamin C, you're going to feel better. But it doesn't give the protection, of course, that we're talking about.
Exactly. And the problem with just taking a lot of vitamin C is just that how much you just excrete it, right? You have yellow pee, and having that liposome in there is really what is the magic bullet that gets it through the stomach acid into the intestines for the uptake, right?
Correct.
As a vitamin C molecule that's
almost complete uptake. That's the other thing too, is
there you go.
Everybody, when I first took this, it was because the company sent me a bunch of C, they wanted me to try it, and I wasn't interested, and I got sick. I got the flu. My office had closed down in Colorado Springs. I couldn't get IV vitamin C. I already had taken 10 grams of regular C and had horrible loose stools. And I remembered one thing and one thing only, because I didn't know anything at all about a liposome back then. They said, well, this doesn't have the bowel effect. It gets absorbed very quickly. So I said, oh, well, I can take some more. And I took 5 packets, and I felt better an hour later than I had after 50-gram IV vitamin C. And I said, I think, Dr. Idiot, it's about time you learn and figure out what a liposome is and try to figure out what just happened to you.
That's right. That's right. So it's just a whole nother way of taking vitamin C where you don't pee it out, right?
Exactly. No, this is almost a long-acting form of vitamin C, because it virtually all gets taken up, and when it finally does get into the bloodstream or lymph, it doesn't get excreted; it goes into the cells. So you really don't excrete that much of the vitamin C content when you take it in the liposome form. That's true.
Yeah. Yeah. Well, that's a great nugget for anyone who's, even thinking about it and going to get even a dental hygiene appointment, load up on that vitamin
absolutely.
C.
Yeah,
Day after. Wonderful way to go.
Very quickly, I mean, one of my most dramatic cases some 20 years ago, I don't know, you might have played a role in the patient's care, I don't recall. But a patient in Virginia called a Huggins clinic in Colorado Springs and said this young woman, 25 years old, had a tooth cleaning.
Yeah.
And very steadily over the course of the following week, she went into a coma. And of course, the tooth cleaning was on top of all these mercury amalgams, and it just
Yeah, the
Just
off
pulled out. But we got her over in Colorado Springs, did some chelation therapy, some vitamin C, some dental work, and very, very, very slowly she pulled out of it. And even though it's not necessarily a topic we'll discuss in any detail, dental amalgams, the mercury amalgams, those are such a double-edged sword. We still have so many traditional cowboy dentists who really don't know what the hell they're doing. They hurt people badly, themselves too, undoubtedly, with their exposure, but they
Yeah.
hurt patients badly by taking out mercury wrong. I mean, I have patients that have lost hearing completely after getting their amalgams taken out wrong, neurological downturns. If you don't have a biological dentist who knows how to do it right, it's really almost better to leave them alone. That's
definitely an argument there.
Yeah.
Because that mercury is going to off gas
Oh.
from, a hot cup of coffee, anything acidic, even vinaigrette dressing on salad dressing, right? Weak acids are going to cause an oxidation at the surface of the filling, directly related to off gassing. Temperatures, scratching, something crunchy, compression.
But of course, a high volume drill that really does.
Yeah. And no protections in place, like keeping the shrapnel from going down the patient's throat. I mean, it's just crazy. And fortunately, there's a lot of conversation in dentistry now about the mercury filling, thanks to the fact that the EU at the beginning of 2025 now banned the use of dental mercury in 39 countries, which is leading to the shutting down of manufacturing of it. So that's all good news. So that is slowly getting to the public awareness, but I haven't seen anything coming through.
Glacier-like progress, but progress nevertheless.
Progress nonetheless. That's right. So, at least the European Union's looking at this has already taken actions on this seriously. Probably the United States will be the last country to do it. It doesn't the ADA own the patent on the mixture between silver and mercury and tin and copper?
That sounds familiar. Yes.
Yeah. So, it's going to be a while for us, but fortunately, the white filling materials are better. They're still not perfect. They're much safer than they were as far as the forever chemicals that are in the material. It's gotten better, but it's still, the real cure or the real solution to this problem is to cure tooth decay. And we biological dentists, and we still haven't done that. And, it certainly wasn't fluoride was supposed to do that. What are we going on about 70 years now with fluoride, and that never happened. And of course, now we know that Utah is the first state that's going to ban fluoride statewide.
Delightful.
It's delightful. We got to just really drill down to what it is about the decay process in teeth.
I don't know if you know this, John, but myself and a bunch of motivated citizens in Colorado Springs, probably a dozen or so, we actually kept fluoride out of the water of Colorado Springs in the year 2000.
Yeah, I was there. You were there.
Okay. Here's the interesting thing, though, and this is a lesson to be taken for vaccines and a lot of other things, is you're undoubtedly dealing with a completely closed mind, okay? And so you have to take a different approach. What happened with the fluoride, and like I said, this could be a principle that's extended to a lot of the issues that we have with vaccinations and all, is we had experts come up to the board of the city, the governing board. They had already spent several $1 million on fluoridation equipment, so that was a real negative on us. They already made the investment.
Yep.
And we brought in people to show the articles, and mercury does this, and this does that, blah, blah, blah. And it fell on deaf ears.
Yeah.
And so at that point in time, I got together with some of my friends there, and I said, we got to change the approach. Okay, we know that the hydrofluorosilicic acid that they use to fluoridate water is a heavily contaminated source of fluoride that's well established to have different levels of arsenic, mercury, and other things in it. Okay. And we're really just paying, we're paying a company money to get rid of their toxic waste. I said, what we need to do is let's completely shift gear and make fluoride the good guy. And so we started a movement called Info. It's not fluoride only. And we said, we give up. Yeah, fluoride's probably good, but if you're going to put the fluoride into the water, you got to put fluoride in the water. You can't be deliberately putting other toxic heavy metals in the water along with this wonderful tooth and life-saving fluoride.
Mm-hmm.
And lo and behold, we prevailed. So we see similar things too in our food supply too, where they put in metallic iron filings in our food. It's incredible, but you first need to find something that your semi-psychotic opposition can agree on.
That's right.
Okay, and then work it from there.
Yeah, yeah, and that's proven to work pretty well because we were able to make a big change in the Colorado Springs water supply that way back then, and
we've not been fluoridated since. I mean, they have some natural fluoride in the water. The Rockies have a lot of that, but
yeah,
but they've, as best I know, I've checked several times online, and we have probably one truly tangible victory I can look at in my life is I played a role. I wasn't it, but I played a role in making sure that untold numbers of babies weren't poisoned with fluoride, as well as adults.
Yeah, it's good work. Well, let's move on to the subject of why don't we talk about the overall importance of the mouth and the health of the gut, and the overall health of the systemic health in relation to the gut wall, and with the mouth being the beginning of the gut wall. And so, what are your thoughts on what would you say is the relationship of the mouth to the gut and the gut to the health of the patient?
Enormous. The first thing, though, and I'll try not to be too vociferous about this and make it as concise as possible, is to, before we appreciate what's provoking a problem, we need to know, and this is what I'm writing about in my new book, What is Disease? Disease is, it's not caused by, disease is excess oxidation. So the more biomolecules you have inside your cell that are in the oxidized, inactive state, the more disease you have. It doesn't cause some other disease, it is the disease. Right. That's number one. Number two is, what is the only thing that causes excess oxidation? It's toxins. That's it. And that's why a toxin is called a toxin, is because it oxidizes a biomolecule, takes the electron away from that biomolecule, and very importantly, never gives it back. It takes it away and it keeps it.
That's right.
And so whereas with regular antioxidants, they take and give, take and give, take and give, take and give. They're inducing electron flow. Toxins go in, bind the electrons, and deplete the electron pool. And the degree to which they do that is the degree to which they inflict disease.
Yep.
So then that begs the question, all right, if excess oxidation is all disease and toxins cause all excess oxidation, then the overwhelming third question is, what are our major new and ongoing toxin sources on a day-to-day basis? Because that's where our disease maintenance is taking place, and that's where our new disease is starting. As our good friend and mentor told us, Dr. Huggins, you can't dry off while you're still in the shower.
Yep.
You can't come in with a ton of antioxidants and you can do this, repair those oxidized biomolecules so that symptoms go down, the disease go into remission, until you stop the new toxins. The new toxins is the water coming out of the faucet. You got to turn that off and repair. So you have to stop new toxins and repair old damage.
Yeah.
So that brings me then to what are the main sources of toxins, and I look at them as being basically threefold. Okay. Number one is infections. That's how infections make you sick, is because they produce toxins. Period. End of story.
That's right.
Number two, and this is close to an infection, but a little bit different because it's a separate toxin as well, is the persistent spike protein. I mean, we're in a totally different new world now. Ever since we had our COVID and our many, many shots, we have millions upon millions of people around the world now that have ongoing COVID spike protein toxic damage to all the different organs of their body. And number three is heavy metal exposure and heavy metal retention. Let me just briefly say, since we talked about the mercury earlier, in 1999, they had an article in the Journal of the American Cardiology where they did biopsies on patients with very large congestive cardiomyopathies because they were being evaluated for transplant, and they analyzed the heavy metal content in the cells. They found that there was 22,000-fold, that's 2,200,000% more mercury inside those heart cells than in regular heart cells. So we're all closer or further away from the precipice. We're all heavily intoxicated, just waiting for additional things to come along and push us over the edge. And that's what the spike protein does, which is why it looks like it causes so much heart problem. It's because the heart avidly takes up toxins more than any other part of the body. You have the heart, and you have the nervous system and the kidneys, and everything else is in second place. So, I mean, the heart is just churning. So if you have toxins, they're just getting sucked in like a vacuum inside the heart. And so when you come along with a really heavy-duty toxin, you might have the spike protein hitting different parts of your body at a higher level, but they're going to make the biggest impact on the already heavily intoxicated heart. Okay, so and then, of course, number three, not to be not least for sure, not last but least, is the mouth. As it turns out, you have basically superficial and deep gum infection, gums and periodontals. You have infected teeth, either by dental procedure, root canal, or by spontaneously abscessing. I mean, as people get old, you think an old person who can barely walk has big, powerful bones? No, their bone has gotten weak too. Their jawbone is osteoporotic too. So it doesn't take much, and you split the bone, and next thing you know, you have pathogens inside the pulp. So it looks like for no reason at all, you got an abscess too.
Yep.
So you have the gums, you have the infected teeth. You always have infected tonsils as well when you have those infected teeth. It's impossible not to, because they're in direct line with the lymphatics and the blood and the venous drainage of these infections in the jawbone.
Yeah.
And finally, well, not finally, because there's a few other things, I sort of had to relearn this. I mean, when I was with Dr. Huggins, we published a paper where he would routinely, I think you recall, look for cavitations with a little short burr at all the old extraction sites.
Yeah.
And I spent a whole weekend going through charts and looked at over 100 charts and then published an incidence of cavitations. Well, with the large teeth sites, the molars, cavitations were present 88% of the time. So 88%, almost 9 out of 10 cavitations that were routinely extracted in the teeth produced cavitations as a result. And of course, you know, you've done a lot of cavitations, Dr. Huggins has, but it sort of faded into the background to me. All right. And then I just started talking about the active infections. And then just recently, I'm going to a conference in Buenos Aires in October. And the person that was started this is a lady that's helped us with the Orthomolecular Medicine News Service do translations into Spanish, and she's learned all about the mouth and this and that. Turns out, and she wrote a book about this and sent me the book and asked me to write a foreword, and I was pleased to. She had been deathly ill for 3 years. I mean, autoimmune disease, glomerulonephritis in the kidneys, no energy, couldn't walk across the room, couldn't sleep. I mean, her life was, I mean, had she been a less stable person, she'd have killed herself. I mean, she just was really down to nothing. And she got her cone beam examination of the mouth, all right? All the teeth looked fine, but they had sort of a pretty big space. And lo and behold, she got a huge cavitation in the back of her jawbone, cleaned out, and that was it. She was fine. And it just really overwhelmed me because I realized that I had let myself get too completely shifted away into the active infections. And I still think there's a lot of people, I don't have data on this, but I'm quite sure right now, we know there's a lot of people that get their heart attacks and their disseminated disease throughout the body because of the infections coming from the jawbone, coming from the tonsils. Dr. Issel showed that too.
Mm-hmm.
And from large cavitations.
Mm-hmm.
Small cavitations are inconsequential. If you've got a really small cavitation, doesn't matter how horrible the pocket is, it's so completely encased by bone, it's not going anywhere. But when they get bigger and they start tunneling down around the nerve, start affecting the next teeth, they can go from being inconsequential to the most consequential.
Yep.
And so it's all part of the big package. And of course, to a lesser degree, and this is the case with me, I think you recall, is when you have people who have chronic sinus problems. I'm sure the ENT doctors don't know this, but fully 70% of the time, someone who has chronic sinusitis has at least one infected, abscessed maxillary tooth abutting the sinuses.
Yep.
I mean, but how many of your ENT doctors refer their chronic sinusitis patients to you? Probably, maybe none.
Yeah.
So, and it's just another thing. This is another thing. We're getting back to the dental medicine.
Yeah.
We should be having communication. The,
Yeah.
the doctors are just as bad off at thinking dentistry is unto itself as they are in thinking they're unto themselves.
Yep.
So, so that's it. And those are the biggies. I mean, there's not a disease that they don't cause. There's not a disease they don't exacerbate.
It's like when I train dentists now, I teach dentists without a cone beam, there is no diagnosis because symptoms are unreliable at best. Whether you have, because people think, well, if there's an infection, there has to be pain. Well, no, there doesn't. And that was even a hard thing for me to accept as well. But nowadays, when I just think every single dentist, biological or not, should absolutely have a cone beam on an adult patient, regardless of symptomatology or regardless of chief complaint, regardless. Do the patient a favor and look at the cone beam and look at the bone densities back where the teeth have, like the wisdom teeth have been taken out, and do the, and take the time to read the cone beam around all the roots of all the molars.
You know
Right.
what I add there too, John? And it really, I'll be honest again, it was this lady's experience that sort of jolted me back to reality here when I thought about what Dr. Huggins routinely did with all his patients is even now with the cone beam examination, cavitations are considered the invisible osteomyelitis. You can have a lot of stuff there, but you still have a little bit of matrix of bone, just enough so that it's not a black hole. It's a black hole with stuff in it.
Yep.
And point being is, obviously, if you see something really significant, you go straight forward. But for those who are interested in my opinion on this, when I talk to different dentists and everything, I think part of your total dental revision, now not on all the front teeth, but on from the middle teeth back, wherever you've had an extraction, you should do one of those quick drill bit hits to see if you fall into a hole. Definitely for sure, with the wisdom teeth side. I mean, those are like 90%.
Yep.
No matter what the X-ray shows, no matter what the cone beam shows.
Yep. I agree. Well, the cone beams will give us a bone density reading back there.
Oh, it will. Okay.
Yeah,
Tell me about that.
It's called Hounsfield units. So HU stands for Hounsfield units. And as you are taking the mouse and the cursor on the slice of the cone beam, you can get a reading that gives you the bony density in that right where the tip of that cursor is. So you can move it around inside the cavitation. And so amongst the biological dentists now, we believe that anything north of 250, positive 250, is indicating that there's some bony, there's bone in there, bone marrow in that particular area. You know, cortical bone, when you hover over the cortical bone, you know, it starts around 1500, goes up to 3000, especially in the mandible, the densest bone in the body. But, you know, in the cavitation site, anything below 250 is subject to diagnosis of a cavitation in that particular area. But I've seen negative numbers in there all the time. Like it'll go from 200 and then you find a little spot where it's like a negative 200 in there. And that is no bone. Okay.
So that always mandates exploration.
Exactly. And soft tissue is even going to be below 0 and 100. So if you're in the negative numbers, you know it's fluid. Then the question is, what's the fluid in there?
How often do you find, or what sort of numbers, if you can, do you routinely find in someone who's had all 4 of their wisdom teeth extracted over those areas?
Depends a lot. It depends a lot on the health of the patient. But of course, what did they grow up with? Organic food and good air and good water,
right.
Good love and good sunshine. I think those people have much better building.
So maybe less so now than 20 years ago.
Oh my gosh. 90%.
Because like I said, 20 years ago, I saw them 88% of the time. But we have a whole new generation of people now, like you say, that have different diets, different supplementations. But I think maybe, just so nobody accuses you of over practicing, the idea would be to, if somebody comes in with a specific problem and you take out their root canal, their abscess tooth, inject their tonsils with ozone, methylene blue, and they get better and their CRP goes back into the normal range, you can let it be. But if they don't get all those benefits, then you do need to arbitrarily explore the wisdom tooth extraction sites.
No question. No question. I mean, I land a little more on the side of biological dentistry where I'm more strict. And, as you know, Tom, I've built protocols around what do we do in advance, before, during, and after. We have a whole protocol for it. But, nothing has changed in the technique of tooth extraction, even at the specialty level with the oral surgeons. I mean, how many people that are watching this have had a tooth pulled where they pull the tooth and it's an open hole, right? It's just, you pull the tooth, the doctor pulls the tooth, you bite on gauze and you get your pills and you go home. And until the technique changes to where we get the connective tissue ligament moved immediately during, like, soon as the tooth is out, well, the ligament, that's why the tooth comes out, is because the ligament tears. And half of that ligament stays attached to the tooth and that gets thrown away. But the other half of that ligament is in there lining the socket walls. And if you've got all these blood vessels coming into that ligament and you've got all that sensory innervation coming into, and, autonomic innervation coming into that ligament, and if that's not removed, then, like you said in your book, your body really has no physiological awareness that the tooth has been taken out. And
right. I mean, when you have the periodontal ligament right here, and the part of the tooth, and that was never taken out, those osteocytes have no idea there's a hole on the other side of the periodontal ligament. They have no biological impetus to start growing.
And absolutely. And not only that, it's a surgeon's job to establish a blood supply in a surgical site.
Sure.
So if the ligament is left behind, the bleeding is going to be a fraction of what the bleeding is going to be when the ligament's taken out. And the bleeding is where the immune system comes from. That's where the oxygen's coming from. That's where the nutrition's coming from. That's what that's where the platelets are coming from, right? So in order to get a blood clot and get a healthy one at that, the ligament has to be taken out. So I'm very strict about that. And I just think there's so much more that when the tooth is out, the job is not done. You take that further. And I would even say that I believe strongly that platelets need to go in the hole to give you a blood clot that is mature instantly, because you've got the platelets there. So you've got and what do the platelets do? They recruit the immune system, and it recruits the stem cells. And short of placing all the platelets and filling up the hole and stitching the gum tissue and getting it to come the direction called closed and giving an ozone injection into the platelets, you've got yourself a pretty pristine wound there that I believe does not require the use of pain pills afterwards, because patients just aren't going to have an inflammatory response. It's reactive. It's going to be a proactive inflammatory response.
And you bring something else to mind here. I don't know if you recall this. I'm sure you do. Hal was always on the look for PZI insulin, protamine, zinc, insulin.
Yep.
Why protamine, zinc? Because it's very long lasting.
That's right.
It would stay in place for 8, 10, 12 hours.
Yeah.
And right at the injection site, he'd always inject, I think, 2 or maybe 3 units of PZI.
Yeah.
And the thing is I'm not sure Hal knew this. I mean, Hal's a brilliant guy, but as it turns out, empirically, it's been known for a long time that insulin is a healing agent.
Mm-hmm.
But what insulin does more than anything else is it pulls vitamin C into the site.
That's right.
So it pulls vitamin C in, it pulls magnesium in. It's everything that you want to have at a healing site. And so I don't know if we can still get PZI anymore, but I know a lot of times I think of something, then I forget about it, then I think about it again, then I forget about it. But whatever the longest lasting form of insulin is these days, I think it's a good idea to put a couple units in the jaw by the extraction site. I think that's a great kick in the butt, especially when you're at the same time you're giving them a whole bunch, well, especially if they're getting an IV, but if not getting, when they're getting a whole bunch of good oral supplements, good oral vitamin C and magnesium, etc., then you're right. I mean, for myself, you working on me and some of the other people that Hal had all the time, and sometimes an extraction involved.
Yeah.
I never had the desire. I mean, I wasn't trying to be stoic, but I never had the desire to take any type of pain pill. There was just no discomfort there once the anesthesia wore off.
That's right. Because you haven't had an inflammatory response that was actually directed towards healing instead of directed or forced into reactivity because the infection's still there.
You take out all the site that was inflammation. You take out all the tissues that most acutely needed the vitamin C. So that's all that's left is a little rib of tissue. Give it some good nutrition. It's not inflamed or irritated, and it just comes right on in.
Yeah. And people wonder why they hurt so bad why dentistry has had such a bad reputation over the years.
Exactly.
And it just hasn't been practiced properly. Like, what do we need for these wounds? What do we need for these patients? And that's a great big conversation. You can get into airway, oxygenation in the blood, and O2 satin. You can get into sleep quality. Are people getting down to their level 5 REM sleep where they actually can detoxify and the brain can detoxify? Is that even happening? And people wonder why they have dental problems, and when they wonder why dentistry, when they get dentistry, it just doesn't work very well. And for those people, okay, we have the pharma, and pain that hurts. Nobody wants that, but it's something that's going to stifle the inflammatory response instead of, like you said, being dental physicians here and looking at the body and the mouth during a surgical experience in such a way where we're looking at it biologically, where we can use injectables like, you mentioned PZI. There's a whole lot more as well you could add to that, and that's really truly state-of-the-art biological dentistry is to have
You
those
know,
things.
I don't know if you've heard me say this before. It's in my book. And a lot of times when I make a presentation, is I'm going to tell you something right now, and I'm not telling this to you to exaggerate or be over dramatic, but to tell you how significant what I'm saying is. And that is, number one, the worst thing you or your family member can do for your general health is to see and utilize on a regular basis a traditional dentist.
Totally agree.
Number two, conversely, the best thing you can do for your health, you and your family, is to see and use a qualified biological dentist.
And I'm glad you said qualified, because they're,
Oh yeah, no, there's a lot of people jumping on the bandwagon. Yes.
yeah, you can go to a weekend course. You can go to the biological conference for the weekend. You can put biological in front of your name dentist, and you compete on the same level on Google with any dentist that's got 35 years experience like I do. And it has built the whole protocol around what are we doing for teeth? What are we doing for jawbones? What are we doing for the entire gut system? As part of the treatment around a dental experience. So, I really want to caution people that when they are looking for a biological dentist, I think the first question to ask is, what does a so-called biological dentist do with a toothache?
That's good.
It's the best question.
Let them define themselves. That's a good idea.
Yeah.
I'm gonna steal that.
Yeah, good. Because the answer is, well, I either keep it alive or I kill it. That's it. Because it's going one way or the other. Once a tooth, and what's so interesting about teeth is it's the only body part that cannot swell. Otherwise, it won't fit in your mouth. So the inflammatory response inside of teeth is different than everywhere else in the body. And that's why biological medicine is so important to, and I talked about inflammation earlier, about steering it instead of suppressing it. Okay, just to use it as the tool it is. Use fever like the body does. Use pain. Pain's a tool. Use swelling as a tool, but a teeth can't do that. Use loss of function. These are the cardinal sign. The cardinal signs of an inflammatory response if it's there. You got pain, swelling, redness, heat, dolor, calor, rubor, and what are the 4 Latin words? Pain, swelling, redness, and fever, right? So getting inside of the blood supply of a tooth, I feel, is a very important treatment protocol for a dentist to be able to inject upstream from the arterial blood supply of a tooth and to pay attention to the lymphatic system that drains it. It's critical on the the managing of the inflammatory response inside of teeth. So now back to the toothache. How do we make a toothache go away? Well, we have to ask the question of what got it there in the first place. Was it decay? Was it occlusion? Trauma, functional trauma. Is the tooth stress fracture? Because teeth are not bones. Bones will heal if they're fractured. Teeth will not. Or is it all the above? And that's why you need a dentist who looks at the physical damage and the physical environment of the tooth, but also looks at the autonomic regulation too. Is the tooth in parasympathetic, or which is the rest and relax, or is it in sympathetic response, which is the fight or flight? And a tooth will not heal in a sympathetic autonomic regulatory response from the body. The tooth must be put in parasympathetic so that it can rest and relax and chill out and detoxify and heal. So that's so important. And so back to the question about, is the dentist biological or not? I think the answer is if the standard of care for a toothache is a taxidermy appointment or an embalming procedure for a toothache, then that's not a biological dentist. And there's a lot of biological dentists out there that are using lasers, which, I did a course on root canals about 2 weeks ago. I just got done filming it. And I get into all the technology and is it a better root canal? Hell yeah, it's a better root canal, but it's still dead, damn it. It's still the dead body part.
About lasers and sterilization, and tell me if you disagree with this, because I think actually most dentists, and definitely all the lay people that are watching it happen, if you talk about a laser, generally you realize it only sterilizes in a straight line.
That's right.
So it doesn't sterilize at a 45-degree angle or anything like that. So number one, you're only going to sterilize directly what's in front of it. Number two, and here's the funny part. When you put a laser down into a tooth, the whole tooth glows. And emotionally, that's like, oh, I'm sterilizing the whole tooth. No, you just flip the light switch on in the room and you're lighting up the tooth with nothing that has anything to do with sterilization. But I think they see that whole tooth light up and they get the emotional feedback that they're actually sterilizing the tooth. Yeah. Not that it would matter if they did, because you wiped out the pulp and it would become rapidly reinfected anyway. But the fact of the matter is, scattered light is not laser light.
And the science on the lasers, because I own this laser that we're talking about. I own the laser that does actually side firing. You get 270 instead of a straight line, you get 270 degrees firing out of that. It's still, even side firing is not enough to powerfully, well, I should say sterilize, because we have to use that word. You can powerfully disinfect the inside of a tooth, which is what I think the laser does, until I see the science that says it's sterilizable, which I don't think it is. And even if it was sterilizable, 100%, like you can kill every pathogen that's in and blow the lid off every colony that's inside of the, if it's migrated into the dental tubules all the way to the cementum and the ligament. Even if that was possible, it's not going to stay that way.
No.
Because the bugs are in the body, they're in the blood supply, right?
Well, I don't know if you know the biological reason for this, because I don't, but I do know specifically and recall that when you have a normal, healthy tooth, you have a natural fluid flow that goes from the tooth outward.
Like a fountain.
Like a fountain.
Yeah.
But when that tooth is dead or infected or root canaled, the fluid flow is in the opposite direction. So even if you knocked out every bug, 10 minutes later, they're there again.
Yeah. Well, once the tooth is dead, there is no fluid flow. The fluid flow is dependent on vitality. It's just when the vitality reverses. Okay. And that was Steinman's work from the late 60s as to what was it that reversed that fluid flow. And unfortunately, we lost Professor Steinman right when he was, that was his thesis question at the time. That was the question, is what is it that makes that tooth, a healthy tooth that was a fountain, what makes it become a sponge?
Right at his peak of production. Huh?
Right at the, he was, and I've heard that what he felt it was toxicity that was reversing the endocrine function of the parotid hormone that's in saliva that was when in contact with teeth that would regulate that internal fluid flow from the pulp through the dental tubules all the way out of the tooth, so that the biofilms that would live in the periodontal pocket would not come into the tooth, that there was a hydrostatic healing response that would prevent the toxicity of the sulcus or the periodontal pocket from becoming a part of the internal toxicity of the inside of the tooth. So that's a beautiful mechanism, is as if a tooth can sweat and keep the bad colonies, the colonization and the toxins on the outside of the tooth structure. Right. That's pretty a remarkable fluid dynamic inside of a tooth. And that was fascinating. And I really think that the answer to tooth decay lies in that question. If we are going to solve tooth decay, we have to figure out what is the is there a healthy hydrostatic pressure inside of a tooth that's, is the tooth forcing toxins out, or is it letting the decay in? Right? Instead of, the common narrative with tooth decay is we're going to blame strep mutans. We're going to blame it on a bacteria and the bacterial poop, which is no question that's there, but what's it doing when it's there? Is it being alkalinized? Is it being buffered? Or is there a mechanism to get rid of it? Or is there none of that? and people have these rampant decay problems in their mouth. And, you know, and then here's dentistry with all these mechanical solutions to solving it with a filling, when that's a physical solution to a biological problem, and that doesn't work. So, you know, I'm not saying don't go in there and do the dental work and fill the holes and get the wound as cleaned out as you can and sealed. No question, slows down the rate. But what is it about the patient that got them in that place in the first place? And that's where I just think the future of dentistry is really for dentistry to be a healing profession and solve the tooth decay issue, which is the most common disease known to mankind, is a cavity. It's the most common. And man,
you know, if we could legitimately regrow teeth before people got severely ill,
yeah,
we could make the average lifespan about 115.
well, that's a really interesting question. And, you know, and there's a lot of patients ask me that. Well, I heard they're regrowing teeth. Well, there might be regrowing some tooth structure down in the
exactly.
jawbones of rats. But if you don't have, you know, that tooth is never, that whatever mineralized product called that looks something like a tooth is sure as hell not going to erupt inside your mouth without the hormones there during puberty to get it in there, right? You got to have the root development. So, you know, all this talk about growing tooth structure in rats, I'm not having it, because
I'm not saying they're any close to it. But you know, when we start looking at all these 3D printers, there's some crazy stuff that's happening too. So
yeah, no doubt. I just think that you know, first thing we got to do is clean up food supply. You know, if we're going to solve decay, we got to fix it. We're going to solve everything. We got to clean up that food supply. And so I'll just leave it at that right now. And as a reactive tooth mechanic on the other end, I'm just going to do it as best I can and keep people from going through these.
Well, ironically enough, it looks like with RFK Jr., none of the food companies want to be the bad guys. So they're all, as best I can tell, they're all on board with, sure, we'll stop putting those food dyes and petroleum agents and everything in. So we're probably going to start seeing some good results over the next 5 years or so.
I think we're going to start seeing some really good results with that. Thank God. Yeah. So, you know, I want to be attentive to time today. And I feel like, you know, we could certainly continue this conversation. I definitely would like to with you, Tom, and give people good information and hopefully capture a couple of dentists in that net to start opening up their minds to the new way of practicing, because we definitely need more biological dentists right now.
No doubt about it.
Severe shortage of that. And we definitely need to get the cost down so people have more access to it. So
I know it's frustrating to you. It's very, very frustrating to me to get an audience of people who were intelligent, highly motivated, want to do all this stuff, and I've got nowhere to send them. Or you know, I can't, you know, unless they have unlimited pocketbooks and they can travel anywhere you want them to travel. They say, well, you know, I live in
middle of nowhere,
Middletown, nowhere, and wow, and I can't afford blah blah blah. Well, it's tough. It's tough. So we just
it's really tough. And you know, I had a reputation during my practicing years of being one of the most, if not the most expensive dentist, because I really felt like what I had to do is I had to build the perfect protocol around getting patients well. And it just involved so many things, not just a protocol, but you know, in the end of my practicing days, people would come for 2 weeks and stay in Denver for 2 weeks while we did the BioVital and the BioDentist way, and we did all that stuff. And then we, you know,
sort of like Huggins back in the day.
It was like Huggins back in the day. You know, we had the medicine, we had the integrated medicine, and we had the nursing, and we had the dentistry all in one. And, you know, and I don't do a little bit of infection over here and leave the little bit of infection over there. I'm taking it all out at same appointment. It was never too much once I started doing that.
Right.
Patients had these powerful healing experiences. Like, oh my God, I am absolutely a new person. Typically the day after I got the surgery done, I'm like, yeah, I know, it's a good thing you can have the resources for something like that. But I've always had a dream. And in the dream is this: I think that we need to have that level of biological dentistry accessible to everyone, regardless of ability to pay. It just breaks my heart, all the people that would come towards me as a biological dentist because of they heard what we do and the results we get, but you know, can't even close to afford it. And unfortunately, it's not about me getting rich. And, you know, I got an expensive clinic here and, you know, I make a living at this, but that's it. You know, I never felt like I was doing dentistry so I could buy more stuff and get rich. And, you know, I was just here to heal the people, but I had to do it in a certain way. And we can talk about that later. But I still have this dream of what are we going to do? You know, if we can, I just believe that if there's some way that we can, as a country and as a society, we can afford the jab and all the jabs, and we can print the money to do that, then I think we can maybe print the money. And imagine, Tom, this is a good question to end with. What do you think if every single person in this country, let's just use the US, for example, not the world, but in the US, every single person that wanted biological dentistry and they wanted all the infusions and all the things that we do and all the liposomes that we can give them, and we give them dental appointments and we do it right. Okay. What do you think that'll do to our culture?
Well, we'll have a lot of doctors who are farmers instead.
Agreed. Yeah. And we'll have a lot of people out there.
That's right.
That'll be like, wow, I had no idea this was going on in my mouth.
That's right.
Yeah. So, well, why don't we give it a wrap for today?
Alrighty.
I'll be in touch. Thank you so much for your time, my friend. It's just, I love hanging out with you. And, you know, we got to do this while we're still cracking here.
Exactly.
Yeah.
All right.
Will you be well, Tom?
Take care, John. Bye-bye.
Thanks. Bye.